Okay, tonight is coding session 4, and we're going to start on page 46 of the 2009 ICD 9CM book, the Fay Brown. If you watch this in subsequent years, of course, the page numbers are going to change, but we're going to talk about coding unconfirmed diagnoses as if established. And this can be a little bit tricky because the rules for inpatient are different than the rules for outpatient. Now, in an inpatient setting, and I'm going to kind of go with you through that paragraph and tell you what to underline. When a diagnosis for an inpatient, make sure you underline inpatient, at the time of discharge is qualified or stated as being possible, probable, suspected, likely, questionable, or the question mark, or rule out. What they're trying to tell you is that they think that that is what's wrong with the patient, and therefore they have treated the patient in that same manner. All right, now two things are important there. First of all, we're talking about an inpatient admission, and secondly, at the time of discharge. Now, we have patients come into the hospital all the time with a questionable MI. That's what they're coming in as. We think it's an MI, but during the course of the time that they're with us, we're going to determine whether it is or is not, and so by the time they leave, we will know whether it was or not. And when they leave, we will either say indigestion, if that's what it was, or hiatal hernia, if that's what it was, or we will say MI, if that's what it was. Now, contrast that, though, to the time that the patient comes in, and the whole time they're there, we think they have something, but we're not sure, and we discharge them, and we're still not sure. Now, this would happen mostly in very small hospitals, or mostly in situations where somebody comes in and expires suddenly, and when you don't have any way to really know for sure at the time they leave you what really is wrong. All right, so let's say that I'm at the beach, and I have chest pain on the beach, and they take me over to the small inpatient facility who's not capable of doing any heart catheterization or any stents or anything. So when I come in, they think it's a possible MI, and when I leave, they're still thinking it's a possible MI because they're air evacuating me to Pitt Memorial, where they do have the catheterization capabilities. They didn't take the time to find out if I really had an MI or not, did they? They got me out of there. So I came in with a possible MI, I left with a possible MI. In those circumstances, their mindset is that you've had a heart attack, we're going to treat you as if you've had a heart attack, even if we don't know for sure you've had one. They're still going to run the same diagnostic studies, they're still going to give me the same medications, they're still going to do the same, procedures, lab procedures. So in that case, you code it as if it actually was whatever that diagnosis was, an MI in that situation. Now, stop and think about that. I've gotten to Pitt Memorial, and by the time I got to Pitt Memorial, they found out it really wasn't an MI, it was in fact a hiatal hernia. So you see what you've got is a diagnosis at one place that says I've had an MI, and a diagnosis at another place that gives me a totally different diagnosis. Is that legitimate? Yeah. And those circumstances, it's very legitimate because there's nothing you can do otherwise. Now, one of the reasons that we code that possible diagnosis as being an actual diagnosis is because we're going to treat that patient as if it were that diagnosis. Does that mean we're going to have the same costs involved and the same resources used that we would for a patient that ended up having MI? Yeah. Yeah, they're going to do the same diagnostic studies, the same testing. So yeah, so we have to be able to show why all that big money was spent, and yet when you end up going to the next hospital, it turned out just digestion or hiatal hernia. So we're blending the reimbursement in with the statistical aspect, and we've got to be able to why so much money was spent. All right, so that one is very important. A diagnosis for an inpatient, we're only talking about inpatients. At the time of discharge, only talking about the time of discharge, stated, qualified, or documented as being possible, probable, suspected, likely, questionable, with a question mark, or rule out. Now notice it doesn't say rule out, and we're going to talk about rule, and that's different from rule out. When it's stated in that way, then if the diagnosis actually was established. Now, do you remember my example last week about the radiology group who the lady had a rule-out brain tumor and they coded it as a brain tumor and she killed herself? I want you to think about that, and that will come up when you look at coding 3. I'm not sure which part it'll be, but in the coding 3 tapes, you'll see there's an example, and you'll know why it's so important in an outpatient situation not to code somebody as if it actually existed when it did not. However, having said that, let's put you in this scenario. You went to some small hospital somewhere because you had a lump in your breast. And they took a look at it, and even though they admitted you, they decided after a day or two they couldn't do anything for you, so they sent you on to a bigger hospital. Now, the smaller hospital, when you left there, they gave you the diagnosis of possible cancer of the breast. According to this rule, what would you code it? Cancer of the breast. All right, but you got to the larger hospital and they said, oh, that's not cancer of the breast, that's just a cyst of the breast. Now, how does the second hospital code it? Cyst of breast. But here you have a documented charge, a claim form, everything that shows that you've had breast cancer. And it was legitimately coded. Now, you get ready to apply for insurance for your new employer. And your new employer starts looking at your past medical information, and they see you have a history of breast cancer because the claim form shows it. Can that be problematic for you?
Yes.
Yeah, it can be. So there's some things that just happen, and you can't fix them as far as coding is concerned. You just have to deal with them as they surface. But if they're an inpatient, and at the time of discharge, it's a probable, questionable, suspected diagnosis, the coding rules say you code it as if it actually existed. All right, now, there's some other terms that fit along with that, and that's what the next line designates for you. Things like consistent with, compatible with, indicative of, suggestive of, and comparable with. Note that there is an exception to that guideline, and that is when you're trying to code HIV infections or illness. Code only cases confirmed by physician documentation when you're talking about HIV. All right, so it's an inpatient situation. The doctor has discharged the patient with a diagnosis of probable MI. What do you code it? MI. All right. It's an inpatient situation. The physician has listed it as probable HIV infection. What do you code it?
Nothing.
You sure don't code it HIV infection, do you?
No.
No, that's an exception to the rule. You code only cases confirmed by physician documentation. For these patients, the principal diagnosis is the highest degree of certainty, such as the symptoms, signs, and abnormalities. Now, you're going to learn in HIV coding that we can code asymptomatic situations, we can code symptomatic situations, we can code full-blown AIDS. So there are ways to code AIDS according to the situation that exists, but be very, very careful with that. Look at the last paragraph. Not only is AIDS a tricky diagnosis that you want to watch out for, but when you start coding somebody as having epilepsy or multiple